By the year 2030, an estimated 1.3 billion women worldwide will be in perimenopause and beyond. The physiological bedrock of this period is a severe decline in the body's production of estrogen and progesterone. This endocrine shift triggers immediate systemic pathologies that extend far beyond the reproductive system. Within the skeleton, declining estrogen impairs osteoblast activity, leading to an average drop in bone mineral density of 7 to 10%. Simultaneously, the onset of menopausal sarcopenia causes lean muscle mass to decrease by 0.5% each year, while visceral fat increases. These changes often coincide with vasomotor symptoms, severe hot flashes and night sweats that impact up to 80% of women. Given the scale of this systemic failure, prescribing vague lifestyle changes is clinically inadequate. Effectively treating specific menopausal pathologies requires a modality-specific clinical exercise prescription. We can evaluate the efficacy of these modalities by looking strictly at recent meta-analyses of randomized controlled trials. These trials compare two primary interventions, aerobic exercise and resistance training. The central clinical question is which biomechanical stress treats which specific endocrine-driven symptom. Failing to distinguish between these modalities results in failed symptom management and a compromised quality of life for the patient. Standard clinical trial parameters for aerobic exercise typically involve interventions of at least 12 weeks, with 3 to 4 sessions per week of walking, jogging, or swimming. The data shows that aerobic exercise produces robust clinical benefits for the metabolic profile, specifically driving significant reductions in triglycerides and total cholesterol. It also demonstrates strong efficacy in improving psychological markers, with a proven impact on insomnia, anxiety, and depressive attitudes. However, aerobic exercise has a critical limitation. It fails to adequately treat vasomotor symptoms. The Daly et al. Trial demonstrated that aerobic activity is not an effective standalone treatment for hot flashes or night sweats. This forest plot visualizes aerobic exercise's clinical effect. The 1.13 risk ratio and wide confidence intervals cross the line of no effect. The diamond marker's width reflects inconsistent outcomes. High heterogeneity at 72. The heterogeneity here is 0%, proving minimal variance between these clinical trials. The distinguishing clinical finding is that, unlike aerobic exercise, resistance training demonstrates a significant impact on reducing vasomotor symptoms. Physiologically, resistance training specifically counteracts menopausal sarcopenia and bone loss. Through the process of mechanical loading, high-intensity resistance directly triggers osteogenesis and muscle synthesis. This provides the physical stimulus required to replace the chemical signals lost as estrogen levels decline. Resistance training is the specific mechanical intervention clinically required to reverse the structural and vasomotor declines of the climacteric period. There is also a highly specialized, localized subset of resistance training imperative for this demographic: pelvic floor muscle training. Genitourinary syndrome of menopause affects up to 32% of women in this stage of life. The decline in estrogen causes profound thinning of the vaginal lining and reduces protective local bacteria. This leads to clinical symptoms including urinary urgency, incontinence, recurrent infections, and dyspareunia, or pain with intercourse. Specific muscle training mitigates these symptoms by increasing local blood flow and providing essential mechanical support to the tissues. Pelvic floor muscle training represents a critical, highly targeted resistance requirement for comprehensive menopausal care. Physical exercise during the climacteric period should never be viewed as a monolith. Effective care requires building a targeted clinical prescription matrix. Based on the trial data, aerobic exercise maps to metabolic control, lipid management, insomnia, and anxiety. Resistance training maps to its specific targets: vasomotor symptoms, osteogenesis, and the reversal of sarcopenia. Achieving total symptom management requires a hybridized approach, blending cardiovascular conditioning with intense mechanical loading. This must include localized training for the pelvic floor to address genitourinary decline. Clinical success depends on matching the correct biomechanical stress to the corresponding physiological deficit. By applying these modality-specific, evidence-based protocols, clinicians can fundamentally restore a woman's quality of life throughout the climacteric transition.